So I think, Henry, you now have PARA 603. So this is the 1982 return. You can see you're noted as Centre Director. You treated 22 patients with Haemophilia A that year and 5 with von Willebrand's disease. And we can see there that your treatments are made up of NHS factor 8, a small amount of factor 8, and cryobuline for those with Haemophilia A, and then with cryoprecipitate for those with von Willebrand's. So that was the new policy, treatment policy that you'd brought in as Centre Director to move away from cryoprecipitate to factor concentrates.
But it looks as though there's home treatment, which is largely a ratio of about 4 to 1, factor 8 compared to NHS. Is that right?
Absolutely, I think this would be right. So I would be responsible for ordering that the commercial products, and I would have been responsible for introducing home treatment.
So before you had factor concentrate, did you have home treatment?
No, not really. I can't remember. I don't think so. No, I don't think we used cryoprecipitate as home treatment.
And do you recall whether at this stage you had a prophylaxis treatment program?
No, I don't. I think prophylaxis came a bit later.
Can you recall when that came in?
You see, once you had home treatment, patients quite often actually gave it prophylactically, particularly if they felt they were going to play a football match or do something that could make them bleed. And we were quite happy for that. I mean, I had one patient who did karate, which against my advice, by the way. He was black belt. I said, you mustn't do that. But he would give himself a shot, before doing. But so I think in a sense we had started. And once you started home treatment, so if they were having to give themselves injections 3 times a week, say, because of 3 bleeds on a regular basis, well, you might as well give it 3 times regularly rather than wait for a bleed. So I think there is a sort of slight overlap in that. But the formal prophylaxis, if one did that, you had to see how much of material we had, how much we could afford. And also the home packs. It was important to know how the home packs were organized. And one would have to be very careful about abuse as well. Because prophylaxis wasn't about total replacement. It was about stopping to get a bleed,
And can you recall when the formal program came in?
Sorry, I can't remember because, like I said, there is an overlap between the two.
And just looking down at other materials, you haven't noted it.
Just a moment before you do. You described a process of prophylaxis ad hoc. Somebody going to do karate, play football. When the person on home treatment came back to the hospital and with their record of what they'd used for the bleeds they'd had, of course they wouldn't have had a bleed on that occasion.
No, and we didn't examine the records that closely.
You didn't? No,
because I think it's a question of if on balance they were well, surely I'm happy with that, but as long as they didn't use it excessively, We didn't police it that closely, as long as they didn't go beyond a reasonable use,
So within limits, it was expected they might
Absolutely,
use it. I see.
Yes. I mean, it was inevitable, wasn't it? Once you got the material at home,
Well, particularly, I suspect, if they're young adults.
Absolutely. One of the things about haemophilia care was that you wanted them to be fit. You wanted them to exercise. You wanted them to have as far as normal lives as possible. The better fitness they had, the less bleeds they had. So, we didn't mind at all, as long as it was for the right reasons,
Thank you.
Just looking down at the bottom of that page to other materials, if you had been treating with DDAVP or tranexamic acid, would you have expected to have recorded that there?
Yes, we would, and the reason why it's not recorded, I suspect, is because these are records from the blood bank. DDAVP is a pharmaceutical product that would not be kept or recorded in the blood bank. So the returns were largely prepared by staff in the laboratory.
So this doesn't necessarily tell us that you didn't use DDAVP?
No, we did, yes, that's right. Once it was available, we did use it, but because the returns were not were done by the laboratory staff, blood bank staff, it may not have been recorded.
Henry, can we have PARA 602, please? So this, as I understand it, is a survey of European haemophilia centres. And if we go to the second page, Henry, to the bottom, it says there, please return to Professor Bloom as soon as possible before 20th of January 1984. And then if we go back to the first page, the first question is to ask how many patients you treated in your, each year at your centre, e.g. 1982. And then it's question 2, during the last 4 years, what products have you used? And you set out there the products that you've used, presumably during your time at the Bradford Centre. And we don't see any record there of DDAVP or tranexamic acid. So looking at that, do you think that by the time you filled this in, which seems to be probably end of 1983, beginning of 1984, that actually you weren't using that product at that time?
I can't remember when DDAVP came into use, but if it was there, we would have used it, it's undoubtedly. And tranexamic acid, we were probably one of the first and used it quite commonly, but I think, I don't know, the mind maybe have been concentrating on concentrates and cryo and NHS, I can't remember.
So your recollection is that you did use it, even though it's not recorded in any of the
when it was available, yes. I'm trying to think.
It would, I think, have been available from 1978 onwards.
Oh, then we would have used it, yes. We would have used it, yeah. But like I said, because it was recorded via pharmacy, so it would have been on the green cards, but not in the laboratory. No, we would have used it if it was, because we tried to avoid, as you know. So in von Willebrand's and mild haemophilia, we used DDAVP.
Can I, Henry, can we have HCDO 40228_002?
I think I suspect when I filled that in, I probably had in mind about blood products and rather than thinking of pharmaceutical products,
This is the 1983 return. And we can see here again the pattern continues, that you're treating both at home and in hospital with a mixture of NHS factor and commercial factor. Here, factor 8 and cryobulin for those with haemophilia A, and for those with von Willebrand's, you're treating no home treatment, just cryoprecipitate in hospital. Can I just ask you what your treatment policies were at that time in terms of deciding who had NHS factor and who had commercial factor?
I mean, we followed the UK CDO guidelines. We tried to keep to one product all the time, but something that tipped us towards the commercial was home treatment. The home treatment packs were far better. NHS packs had to, if I remember, had to be made up. They didn't come in ready-made packs, but the commercial were all ready in a nice little box with the needle and everything. The commercial products were far more soluble because they were purer than the NHS, the intermediate. So that may have tipped us because you needed less water to mix. So the
And what was the
commercial
advantage of of needing less water? What was that advantage?
Well, you needed everything smaller, so it was more soluble, less water to mix the product, less to drop, less to inject, rather than a bigger volume. And this is all from memory, and I think that may explain why we got a lot more for home treatment, the commercial product, than using the NHS. Now, in terms of, we would have followed UK CDO guidelines. So for people who weren't exposed to commercial, we would have tried to use NHS. If they'd been using NHS, we would have tried to use NHS. But for home treatment, and these are for severe ones, because home treatment, by the way, was not given for mild ones. They were for very severe haemophilics. That may explain why we got more commercial for home treatments.
So before the UK HCDO provided any recommendations, would you have chosen between factor, NHS factor and commercial factor simply on the convenience of the home treatment packs as you've described?
No, I don't think so. I think from the documents I've given, you'll see that time and time again I said that we prefer NHS products, to commercial. So I think if they came to hospitals, it's very likely that they had NHS. So the infrequent users would have probably had NHS. I think that's as far, but we follow the guidelines,
So there's quite a lot of there's predominantly commercial factor being used in hospital there, rather than NHS.
Yes.
Does that assist at all in identifying what the policy was at that stage? Because I think in your witness statement you've said that you didn't have any problems with supply of NHS factor 8 over these years. You had sufficient supply. Always.
But I'm sure you'll want to talk about that later.
Yes, well, but your recollection is that you always had enough NHS supply.
But
so what the reason for putting people on commercial was because it was more convenient.
Yes, but also maybe I can explain about the NHS. When we ordered NHS material, it was always available, but the official line from the blood transfusion service and the official line nationally and from UK at CDO that there wasn't enough NHS material. So we had to use it, we had to be aware that we didn't use up all the NHS material from the region. So there had to be balance to give other centres a chance to use in proportion, that we used NHS material and we used commercial, but without just using NHS all the time, because that wouldn't have been fair.
So when you say you never had any problems with NHS supply, it wasn't that you could have said to the blood transfusion centre, I want enough NHS product to meet all my treatment needs, all my patients' treatment needs.
That wouldn't have been allowed.
Right.
Because as you've seen the regional guidelines as well. What I didn't know, and it baffles me actually, it still baffles me, is we could have used more NHS if people had given us like a stock control and said, look, we've got this much lying here. Yes, you can have a bit more, you can use more. It was never like that. You ordered and you got. So we had to use our own balance, of how much to use. And obviously one didn't want to go predominantly NHS when you didn't know that there were other centres involved in the region as well.
So was there ever a circumstance where you said to the Regional Blood Transfusion Centre, I want more NHS, and they said, no, actually, all you can have is this? You always got what you asked for, did you?
Yes, we did, yeah. I mean, that's what I meant by, we had never trouble We would never denied NHS products from transfusions. On the other hand, we never knew how much they had that they could spare.
But you didn't feel, as a matter of fairness to other centres, that you could ask for more than you'd asked for, because then there wouldn't be any for anybody else.
Absolutely, and it just makes me wonder that why weren't there sort of regular information about stock control and what was available and what wasn't, and what was costing and what the budgets were, how much was affordable. Because you're paying more for commercial products than NHS. At the end of the day, and I think this is what all the directors would say, we were trying to use the best product that we thought was the best product in the interest of the patient. And that also meant what was also easier to administer, easier to obtain, etc.
So just trying to think back about what the treatment policies were. You said NHS was the best product on some levels.
On some levels, yes.
Commercial product was the best product for other factors like convenience.
Yes, but also, because I don't know the exact dates and so on, the commercial products always had an edge over scientific on producing a better product, while NHS were always following whatever commercial companies first achieved, like the heat treatments and raising the level of the heat, the purer factor rate, etc. So we would always be looking to see what was the most convenient and the best at the time. It's very sad, and I think you probably want to discuss this. Why couldn't NHS keep up commercially, as a commercial organization? Because it was not a commercial organization,
And so, do you have a clear recollection of the basis upon which you gave NHS concentrate to some patients and commercial to others in that 1981, 82, 83 period?
I really couldn't go into detail. I can't remember what the exact, but it would have been on clinical situations and need,
And when you say clinical situations, what do you mean by that?
Well, we've mentioned about home treatment, but as a clinical situation, if somebody was bleeding 3 or 4 times a week, then it's better for him to treat it at home, and that obviously led on to prophylaxis. And then it led on to saying, well, we should attain a higher level of factor, but that's another question. I honestly, I can't remember details of how exactly, but we did follow UK CDO guidelines,
Okay, we can come on to that in.
Just before we leave this page, I wonder if I can just go back to your answers about preferring commercial concentrate for home use. If we look at the figures on the sheet, if we just have a quick look, it looks broadly as though the same total amount of units were used in hospital as were at home. Broadly, it comes to about 290 odd units in both. But there's rather more NHS used at home, proportionately, than in hospital. So at this stage, it may have been transitional.
I think it's transitional, because the NHS would have gone down and commercial would have gone up.
So the next year we should see the total use for home treatment of NHS will be rather less proportionately, and that commercial rather more.
Probably, but we also felt that you should try and keep people on the same product as far as we could, because then you'd know about viral transmissions and about batches.
So the same product would be either NHS or commercial, would it?
Yeah, if you ask me detail, I really can't remember, the exact circumstances. But I can tell you, as a matter of principle,
Well, as a matter of principle, it would seem to follow that if someone had received armour factor 8, for instance, in hospital, they would get it at home and vice versa.
Quite possibly, yes, absolutely.
Well, it would follow, if the principle was keeping him on the same, that must follow, mustn't it?
Yes, but also we would have to look at the stocks in the blood bank. So a clinical situation arises, and there's also stock control in our own blood bank.
So there may have been occasions when you weren't able to do it.
I honestly couldn't remember, but it's not simple. You treat patients as a clinical situation arises, and
Yes.
But the overall principle was try and keep them on the same. There's no doubt that the commercial packs, etc., for children particularly, they made their home packs were so well done, that they must have done a lot of customer feedback, and obviously these pharmaceutical companies were international, and they had to produce competitive products, competitive packs, competitive everything really, which NHS didn't have to. BPL.
In your statement, you say that initially you were responsible for selecting blood products for the centre, and then at some point that moved into regional contracting. Is that right?
Yes. Well, or the other way, there was regional contracting, and we fed in what we wanted.
So there wasn't a time when you were ordering your own blood products for your centre. It was always regional contracting.
When I first started using commercial, the first time I did order it through pharmacy, and I think that was ignorance, actually. That was my naivety, because that should have gone via transfusion, but it was only a small amount. It was almost like experimental. I think it was 10,000 units, which is very, very small. And
is it right that you ordered, or you were responsible for the prescribing of all the products, even for the paediatric clinic, certainly up until sort of 1986?
I think it's better to put it that I was, as a director, I was accountable for that rather than ordering, because obviously ordering and using on a daily, minute to minute, it's a decision, it's a clinical decision made by the doctor who's actually, or nurse, looking at the patient, But yes, I was the director.
But the decisions, in terms of the decision that you had, the input that the centre had, if I can put it that way, into the regional contracting arrangements for the supply of blood products, that was your job. It wasn't something that Dr. Minford got involved
job.
with.
Entirely my responsibility.
Can we look then at Henry, PARA 5015. So this is a letter from Dr. Swinburne to you, dated 7th of July 1983. And she says, I've discussed the supply of factor VIII and related products with Dr. Tovey. So he's from the Regional Blood Transfusion Centre. In light of the discussions we had about AIDS, he and Dr. Raja have agreed to look at the question of cryoprecipitate and to maintain the supply. I'm going to come back and ask you some questions about that in due course. There's a second paragraph I just want to draw your attention to now. Dr. Tovey would like to know predicted requirements for 84-85 and suggested suppliers towards the end of September. Following this, he'll make recommendations to the RHA, and then they will ask for tenders. This arrangement worked well last year, and we're lucky to be one of the regions which so far has had an unrestricted supply. So there, am I right to understand that so far had an unrestricted supply is talking in fact about NHS product, or is she there talking about commercial product?
I don't know.
Don't know.
Dr. Tawi was the head of the blood bank, regional blood transfusion centre. Like I said, I never had. There are documents that you have where it is mentioned that if you used exclusively commercial products, NHS products, there wouldn't be enough for the region. But I never saw the actual figures. Now this is 84-85. When I think that may have been a time when NHS was producing a lot more factor. I think that there was a time when it was reaching self-sufficiency, but I couldn't tell you the detail.
And what's suggested here is that the process is that the directors suggest commercial suppliers to Dr. Tovey. He then makes recommendations to the Regional Health Authority, and then the Regional Health Authority deal with the tendering process. Does that accord with your recollection?
That's how the system worked, yes. But I think the prices that they got from tendering, I think some other directors have mentioned, you could actually get it cheaper by doing it. But it's through the tender, regional tender, yes, regional.
And then if we look at PARA 5010, we can see in that last big paragraph, for the reasons stated before, this is a letter from you to Dr. Swinburne in July 1983, so the year before. I would be grateful if Cutter Laboratories were considered as one of the suppliers. So here it seems to be you having a discussion with Dr. Swinburne about who should be put forward as one of the potential suppliers to Dr. Tovey. And you say it's important that there should be flexibility in choosing various commercial firms, and the Haemophilia Centre director should not be excluded from showing their preferences. Can you recall why you had a preference for Cutter at that stage?
I didn't. I think the principle was we shouldn't have exclusive contracts with one commercial company. Competition is good because that reduced the prices. But there was also the question of flexibility, that while we were treating in year, you found that one product, say, had showed up virus or infections or something, we could remove it and still have an option from another company. But other than that, there was no reason for choosing one over the other. Could have been any.
And so we'll see that, I think, in the next document, which is PARA 5020. And this is a letter from Dr. Swinburne to Dr. Tovey. So this seems to be at the point where the tenders have come back in. And we look, there she sets out the requirement for product. Then she mentions that another TV programme on AIDS, some reluctance to use commercial factor by a few patients, but in general the policy is unchanged. And then she goes on to say, I have had quotations from Armour, Immuno and Alpha, so it seems that the quotations were coming directly to Dr. Swinburne. Is that, do you recall that?
Well, it should have been through Dr. Tovey and then to Dr. Swinburne, because they were both in Leeds, and Leeds was the bigger centre. So they would have, you can see from the, St. James is using nearly 3.5 million units, while we were using 800,000 units. So they would have the bigger say.
Yeah.
And they were using more commercial up to that period than NHS. Well, we were probably half and half or roundabouts.
And would she have discussed, she CC'd you into this correspondence, would she have discussed the choice of supplier? She then goes on to make the choice of supplier with Cutter. Continue using Armour as the main supplier with Cutter as backup. Would she have discussed that with you?
No.
So that's a decision she made on her own for the region?
Yes, on the basis of the information we gave, obviously. We gave our views, but she would have had to look at the region, not just Bradford,
And so she's making what looks like the only consideration she's giving to which product is on price, and that reflects what you've just said to us, that it could be any of them. They were much of the same, much of a muchness. Was that the view at that stage?
I think if you negotiated individually with companies, you could reduce the price, but obviously this is a regional contract. But Dr. Swinburne or Dr. Tovey would have had to look at what Harrogate, York and Hull have had to say, as well as Huddersfield. That's nearly 1 billion units there, or same amount as Bradford. So I don't know what their preferences were, what they said, you know.
And was price, were there any other factors that you took into account or that you were aware that Dr. Swinburne took into account when deciding between different commercial companies, different pharmaceutical companies for this contract?
Well, I was very fearful that as time went on, that any of these commercial companies could come up with a problem, which they did, as we found out, history has shown us. So it was a good thing not to put all your eggs in one basket. We were desperate for knowledge, absolutely desperate. And I think I've said in my in my response, to the questions, the commercial companies, the reps, would come and see us, and we would get information from them. The BPL, you'd hardly see them. And I used to complain. I've actually put formal complaints. And why aren't we seeing them? Because I want information about the BPL, more about the BPL products. Obviously, we had input from UK CDO and so on, and what we saw in journals, in the various communications, and I've given you a bundle. I think the commercial companies were probably about the same, but we were fearful that things could go wrong, and I don't know what, at that time it was very difficult, but at least we had a choice here,
And so when commercial companies used to come and see you, or when you were considering at the tender, at the point where you're working out which pharmaceutical company to award the contract to, do you recall getting any information about things like where their donor sites were, or who their donor pools, who these companies were getting their blood donations from?
I think there is a letter, and you might have got it already, is that when I ordered my first factor rate, I wanted to have reassurances about the donors. And the answer they give is very simple. Is they're following the American FDA, whatever guidance on the donors. But yes, that would be a question. And in all the things that the big bundle I've given you, there's something from Qatar, for example, in the promotional. The answer is yes, we did look at it, but what they produced was for it was for selling their product.
Yes.
How do we know what actually happens? But we do know now because we've had various television series and investigations and so on.
So your recollection is that you were asking those questions
all the time.
You were getting information back from the pharmaceutical companies addressing those issues.
Addressing may be a bit strong, but we were certainly being told that they conform to whatever American standards have been set for donors. And they varied, they changed all the time.
And what you're saying is, how did we know whether or not that was true or not? They were selling us a product.
Well, you have to assume that there's a lot of truth in that because they were licensed. A lot of the products we used licensed. I tried not to use unlicensed product unless the evidence was strong enough to say that yes, it's a safer product. Use it on a named patient basis. There's a licensed product that would have gone through the procedure to get the licenses, and they probably were tougher in America than they were in Britain. Things were moving so fast. We were desperate for real knowledge, truthful knowledge, the truth. And it only came forward much later, sadly,
And so you at that stage were having to rely on the fact that the licensing authorities must have done their due diligence because you weren't in a position to do it yourself.
No, and we obviously listened to what UK CDO directors said, and they varied in their opinions and their usage. But there were people we obviously listened to very carefully, and that was the great advantage to going to the meetings, international meetings and UK CDO, that you listen to some people and very difficult to say one product was better than the other.
So in those UK HCDO annual meetings, what was their discussion about one product over another?
no debate as such about one product or other, but you could get a very strong feeling on what they were saying in their guidelines, for example, or in their returns. You got, and you talk to people. You know, I mean, the main thing, good thing about all these meetings often is you meet your peers. You know, you talk about it and so on. But you didn't get a clear. They gave recommendations, but they did not give instructions. I think that's been mentioned a few times, the UK HCDO.
Yeah, so the early recommendations from the UK HCDO don't mention one product over another.
No, and they varied a lot, didn't they? Because you had Professor Bloom at one time, NNE Centre used commercial products, and then you had Charles Ritzer very, very much in favour of NHS products, you know, and then there was St. Thomas's that used exclusively commercial products. So you couldn't get a sort of definite idea from the reference centre directors, but you certainly could get a feeling, and not the reference centre director meetings, but there were other meetings where you always had pharmaceutical companies with their stands and, you know, information, and they had to produce printed information for people to look at. We were desperate for knowledge, we were desperate for guidance, and the most important thing is we were desperate for leadership, which I don't think we ever got properly, either from the government or UK HCDO or whatever, and difficult area.
And you mentioned just now in your evidence that you got an idea of what the reference centre directors favoured in terms of product from their returns. Did you see their Oxford returns?
We had summaries of their Oxford returns, yes, because I think, yes, we could see what proportions were being used overall, but they were never complete because there were some centres that never gave in, that didn't want to give their returns. I don't know for what reason, but they did not want them to be made public. I'm saying a lot of this from memory, you know? So going back 30, 40 years.
It's a long time ago.
Yes.
In terms of just going then back to the sort of logistics, in terms of the regional contract, once that, did those products come to you directly from the pharmaceutical companies, or were they held by the Regional Transfusion Centre?
I honestly cannot remember because the blood bank, our blood bank made. I think they were delivered directly. You know, I don't think they went through the blood transfusion service. But I can't remember. The NHS BPL obviously came via transfusion service, but I really can't remember. My main concern was, is there enough in the fridge, you know?
And in terms of then NHS product, any cryoprecipitate that you use came presumably from the Regional Transfusion Centre.
Yes, it did, yeah.
And you didn't have any difficulties with supplies for that? There was always
Never.
Sufficient?
Never.
And we've talked a little bit about the NHS Factor 8 and that you never had any difficulties with supply. Again, can you recall how orders for that were made? Did you make those directly to the Regional Transfusion Centre, or did that go through Dr. Swinburne?
No, it didn't go through Dr. Swinburne. It was direct. And it would be through our blood bank. I mean, it's interesting that the blood bank, you're talking of blood bank were not really trained to deal with pharmaceutical products, and yet they were dealing with them. On the other hand, the BPL material was a pharmaceutical product which was going through the blood transfusion service, which they were not trained to deal with pharmaceutical products. You know.
So I'm now going to move on to a different topic, and that's knowledge of risk. And ask you to cast your mind way back and tell us what you can recall from your medical training. So both, you know, while you were at medical school, but also you described training at the blood transfusion service and so on in the 1970s. what you were told and what you understood about the transmission of viruses through blood and blood products?
Undergraduate days, we would have known very little about it. But once we started the postgraduate, and including doing MRCP or MRC, you did know that blood products, blood transmitted viruses, not just viruses, bloodborne pathogens. I mean, we knew that from the day blood transfusion started. You know, certainly you wouldn't have passed the MRC path without knowing about bloodborne infections. I know in your knowledge you mentioned viruses from 1946 or 1940s. There was, in the 1920s, there was transmission of measles from blood transfusion. And we know about malaria. We know about other protozoals. So it's only logical that anything that's in the human body, if you take a tissue from there and give it to anybody else, whatever that tissue has, there's a potential of transmission. And that applies now as well. So in terms of postgraduate, we would have known about transmission, about blood, from blood products and blood transfusion, because you were giving transfusions. I mean, we were all training as either physicians or hematologists or pathologists or whatever. We were responsible for giving not just blood products, plasma, cryoprecipitate, etc. You shouldn't have been doing that unless you knew that there were dangers to giving these materials.
And what did you know about hepatitis B?
Well, hepatitis B was the well-known one. You know, that the knowledge about hepatitis B, because there was also a question of vaccinations and so on. So yes, but blood was being screened, etc. You know, so that was well established, and then obviously we knew about hepatitis A. What we didn't know enough was about hepatitis C and other viruses. It wasn't just hepatitis C.
So do you recall during your training, your postgraduate training, learning anything about non-A, non-B as it was then?
I'm sure it was mentioned, but I think one of the problems was we did not know how much importance to place on it, or the interpretation. I mean, transaminitis is a strange terminology, isn't it? How can you have inflammation of of enzymes? Transaminases are viruses, and you say transaminitis, inflammation of viruses. Well, that's crazy. You know, but that's because that term was used because of lack of knowledge of what it meant.
And when you arrived, when you were a house officer, a senior house officer, registrar, and then a consultant, what journals or periodicals would you have been reading on a regular basis to keep yourself up to date?
Well, the top journals, I mean, New England Journal of Medicine, superb, which I subscribed to, British Journal of Hematology, which was our hematological journal. I was member of BMA, so I had the BMJ, again, pretty good. The Lancet I didn't subscribe to, but it was very, very, obviously, very good, top scientific. I had a few others as well, which I can't remember, but these are the top journals. Journals that were very, very, very important because they were peer-reviewed, very reliable, especially if you looked at who the authors were. But I think something we've got to be aware of, that by the time things were printed in journals, there was already a delay, maybe 6 months, maybe a year, by the time they got peer-reviewed, corrected, etc. Very good information, but often a bit late.
So you've already said that you were desperate for knowledge. Other sources of knowledge appear to have been the UK HCDO, meetings with other colleagues like Dr. Swinburne in the regional meetings, information from pharmaceutical companies about their products. Are there any other sources of information that you were using at that stage?
Do you know, it's partly amusing actually that often, even now, information that comes out of in the Financial Times is probably quicker than it does in medical journals because of variation in share prices, etc. So I mean, yes, the media was often quite important because they picked up information either in reality or gossip. But yes, I mean, it could have been any sources. It had to be verified. Haemophilia Society was also a source of information.
And we'll come on to some of those publications in due course. So did you watch the World in Action documentary Blood Money in '75?
I must have watched it. I think I must have.
Do you recall it creating any kind of impression on you?
These programs have had great impression on me because I think they show the human face of medicine. They're dealing with people, patients, not just concentrates and viruses, you know. I think this is the sad bit about haemophilia care is it had a human face. There were actual suffering, terrible suffering, you know, and it wasn't just about what we mostly discuss about, you know.
So if we take 1978 as the time that you go to Leeds and Bradford, presumably you knew by then that hepatitis B was a potentially serious condition that could have long-term consequences and was transmissible by blood and blood products. Is that knowledge you had by 1978?
Oh, absolutely. Yes, I did, yes. I think 78, so that was that was 4 years after graduation. Yes, I was doing the MRCP. I think it's something you had to know.
And you've mentioned in your witness statement that you had knowledge and that single donation products such as fresh frozen plasma or cryoprecipitate were safer than pooled products.
But that's very logical,
yes.
Actually, isn't it?
And that's knowledge you would have had by, say, 1978.
Well, we knew, and I think most clinicians would have known that if a single unit of blood or a single unit of plasma or cryoprecipitate has potential of 1 in whatever of passing on infection, British donor, much lower than American and so on, that if you then give 6 units of cryo, which is roughly what we used to give as standard for knee bleeds and so on, then it's 6 times. And then if you go on to 1,000, 500 or 1,000, then it's as many times. And then if you go to commercial products and say 20,000, 30,000, it's just logical that whatever's wrong in there is going to be transmitted, you know.
Now, the inquiry sent you a number of articles that were published in the 1970s on non-A, non-B, and I'm just going to take you to a few of those. Henry, could we have NHBT 5092_002? This is a publication from Vox Sang from 1977. And I'm just going to go over to page 2, please. Right-hand column, last paragraph. Although non-A, non-B hepatitis is on the average less acutely severe than type B hepatitis, it can cause severe acute disease, and more disturbing, it appears to have considerable propensity to progress to chronic hepatitis. The major thrust of post-transfusion hepatitis research must now be directed at developing detection methods for non-A, non-B agent, or developing some reliable method of viral inactivation or removal, which would be independent of testing. Now, do you recall, would you have seen this article, do you think?
I can't recall this at all. It's before I was even appointed, actually, and it's not in a sort of a journal one would be reading as a registrar. It's specialist, but what it says is true, isn't it?
Yes, and do you recall whether or not that kind of information was information that you knew by, say, 1978?
I can't recall it, but I do not think it. I don't think it would have been in the mainstay in my brain, you know, about this, because I wasn't actually practicing proper, hematology to do with blood products, really. But what it says, it makes sense, you know.
So then the next article is R Lit 40228. Again, this is a 1977 publication. So at this point, you are a senior house officer in pathology in Manchester. Again, is this something that you recall reading at the time? So we'll just look at the summary there.
Well, if you didn't read it, shall we move on to something else?
And then the next one is PRSE 303622. So this is September 1978. So by now you're between Leeds and Bradford. I understand you started your senior registrar in haematology in August. So this is coming out just after then. You said you didn't get the Lancet, but do you think that's something that you could have come across, given that it was in the Lancet?
This publication is a major publication.
Yes.
You know, it's a very, very important publication by very important people. I've seen this a few times, maybe not in 78, but certainly in the last 20 years.
Can you recall when you did see it first?
This would have been discussed in the first meetings that I went to, in international or national. There would have been presentations by Eric, Preston, or one of the others, maybe Dr. Trigger, it's possible. So I would have come across it from in the early 80s, really.
So you think that's something you would have come across in meetings as a director of the centre, UKHCDO, or other international meetings in the early 80s?
This material would have been quoted or mentioned. All right, it's a few years later, but it's a very, very important publication, this.
And you don't think it's something that would have been talked about on the wards with Professor Turner, for example, or Dr. Swinburne, when you were working between Leeds and Bradford in 78?
No.
Because those sorts of discussions didn't take place?
No, because we had our own clinical practices, and we never had, hardly ever, I think, we had joint meetings to discuss scientific papers or scientific knowledge or even management of haemophiliacs as such. They were rare and in between. Maybe there should have been more meetings, more regional meetings. I think we had attempted to try and have more regional teachings, but they were rare events, if they were at all,
So just looking at the summary in this paper, systematic screening of 47 haemophiliacs in Sheffield revealed abnormal liver function tests in 77% or 36 patients with a tendency for these abnormalities to persist. To assess the importance of these abnormalities, liver biopsies carried out on 8 symptom-free patients, and a wide spectrum of chronic liver disease was demonstrated, including chronic hepatitis and cirrhosis. So would you accept that by the time you did become aware of this paper, for example, I think you've described in the early 80s, that you were aware that non-A, non-B was clinically significant condition, that carried a significant risk of causing liver disease?
My first unfortunate experience with hepatitis, non-A, non-B, was at St. James's when I was senior registrar. A gentleman came in his 70s, came in for a prostate operation. He was a mild hemophilic. He had never, ever been exposed to concentrates or cryo or any other blood products related to his hemophilia. I think his level was about 34% or so. And he was treated with factor VIII concentrate. Now, I don't know whether it was commercial or whether it was NHS. He became jaundiced within about 3 or 4 weeks, and he died. Now, that's the sort of education you don't forget, that people who had never been exposed, that given concentrates could give them non and non-B hepatitis, and it was not a benign disease. My other experience, which again, and I feel very sad about it because he was a very, very good friend, haemophilia, in Bradford in the early 80s. He had liver disease with a big enlarged spleen, quite advanced liver disease. And my predecessor should have advised him not to have alcohol, which he did, and I used to advise him not to drink alcohol. Now, alcohol and non-B hepatitis or hepatitis of any sort, they don't go well together at all. So one of the things we always did was to advise, and he died because of his non-B hepatitis. So yes, the lessons were there. You didn't need a biopsy to tell me that some of these people died from non-B hepatitis, that it wasn't purely benign disease.
And that first experience that you had at St. James's, that would have been somewhere between 1978 and 1981.
Absolutely,
yeah. And given your previous evidence, I suspect the answer to this is no, but was there any discussion, any opportunity during that period for you to discuss liver disease, for example, with your colleagues who were working in the liver units and liver specialists?
Yes, because if now again, I can't tell you the exact times, but I was in quite close links and talks, and Dr. Maccaris from Sheffield used to come to Bradford and give talks. I used to get people to come to Bradford, even like Tuddenham and Ritza, and they all came and had he was one I could listen to, and I used to, but we had our own liver specialist, and we used to work very closely. If there was any inkling that there was significant liver disease, then I would involve the hepatologists, but we did not do liver biopsies.
So by the time you were centre director, and you've described how you had, you wanted to give people a good training, effectively to make the hospital attractive to clinicians and students and so on, then there was an opportunity for education from liver specialists and so on. But before that, in the era where we're talking about, where you're working in 78 to 81 with Dr. Swinburne and Professor Turner.
Yeah, sorry. My previous answer was when I was already director. Now,
Yes.
78 to 81.
Yes.
I don't think liver disease was discussed at any time. Mentioned maybe, yes. When I was senior registrar in Jimmy's, Dr. Swinburne was an immunologist. We never had any formal training from her about haemophilia, etc., although she was the director. We used to work with the hematologist, Dr. Barnard, and so on. But the focus was on malignant hematology. And Bradford, as you know, had Professor Turner, who was not well and never got involved in. So our education as senior registrar was quite inadequate, And I think this applied to a lot of parts of Britain, by the way. It wasn't just, we were not unique.
So as this knowledge about non-A, non-B was emerging, Would you agree that patients being treated with factor concentrates should have been told about the risk arising from their treatment with factor concentrates?
Patients were quite aware about viral infections because, even they had their own groups, support groups, and certainly when I was consultant, we had set up a group, through the nurses and so on. They were quite well informed by the society and so on. We always told them, well, we always had a program for vaccinations, so they knew why they were getting vaccinations.
For hepatitis B, would this have been?
Yeah. So it wasn't as if they were completely ignorant of the fact that what we were trying to do. What was difficult? There were two areas of difficulty in the early 80s. One was if you had abnormal liver function, enzymes, what we call transaminitis, what it actually meant. So the best thing we could do there was do tests and tell the patients that you've got slight elevation of your liver enzymes, and we're keeping an eye on it. Now, raised transaminases are very common even now, In my case, my transaminases were elevated. The doctor thought I had hemochromatosis, and it didn't turn out that it was a fatty liver. Very common to have raised transaminases in diabetics, etc. So it wasn't just confined to hemophilia. So the interpretation was difficult, and we couldn't obviously do liver biopsies. We could do ultrasound and so on. But they were told that we are watching every 3 months. We used to keep an eye on it, and if they went beyond a certain level, then I would refer them to a hepatologist.
And were they ever told that they had, or that you thought that they had non-A, non-B hepatitis?
Well, now you've got to be careful because you're saying non-A, non-B, and hepatitis. So when you use the word hepatitis, that brings a picture of inflamed liver. Oh, I'm sick, I'm ill. Okay. Non-A, non-B implies there's a C to Z, which we didn't know anything about. So the patients were told that they've got possibly slight inflammation of their liver, which in medical terms is hepatitis. We might not have used that term. And that we're watching their enzymes, and they must not drink alcohol. I think that was something that would have to be told to them universally, that very important.
Would they have been given advice about potentially infecting other people at that?
But if we knew that it was non-A, non-B hepatitis, then obviously we would tell them if they had hepatitis, they would be told. But like we said, the interpretation at that time was difficult.
So
that's why this liver biopsy and all this was very important, because what it said was you can't actually rely on those enzymes only. So you could have very low enzymes and you could have quite severe liver disease, and you could have very high enzyme, in which case you had hepatitis, non-B hepatitis. The way the UK CDO in their studies defined hepatitis is 2.5 times the transaminases, when you were dealing with products that were given. Well, if they didn't have enzymes that were 2.5 times, how could you then say, you didn't know? I mean, did I have hepatitis when I had raised enzymes? No, I didn't.
So in the late 70s, early 80s, you would diagnose, how would you diagnose non-A, non-B in one of your patients with?
Well, you had to look at the enzymes, but also you were looking at, like I mentioned about this patient, where he had a big spleen, enlarged spleen at the same time. Or if there were things related to liver disease, the other signs and symptoms of blood test, then yes, they would be investigated. But simple raised enzymes by itself was very difficult interpretation for us.
So patients that were coming in with raised enzyme levels, from your evidence, very unlikely you would have mentioned non-A, non-B hepatitis to them.
I think it's very unlikely we would have said they've got hepatitis, but we would have said that you have got slight inflammation, which is the same thing. There is a possibility you got inflammation of your liver, and it's not hepatitis. We don't know, but it's something we have to keep an eye on. But avoid alcohol intake.
avoid alcohol, but unlikely those patients would have been given advice about not infecting others because the diagnosis.
Well, if he proved that it was infection, yes, then we would tell them not.
But just with the raised transaminase, you're saying that you wouldn't have known it was an infection.
No, we wouldn't have. And like I said, maybe 10% of all UK residents probably have raised transaminases.
Did you have any patients that had the raised transaminase plus, if I can put it that way, so other features that would lead you over that period to diagnose them as having non-A, non-B?
Yes, there would be, and that's where I would seek professional help.
And you
from
recall
liver specialists.
having patients?
Sorry?
You recall having patients?
Well, I've just mentioned one that died, but one of the impression was that it was a benign thing, as you know. And the thing about the study you've shown was that it's not that benign. Now we know it's not that benign because people like Eric Preston were brave enough to do liver biopsies.
And so for those patients where you thought, well, actually there may be non-A, non-B here, you've described that you would seek help from liver specialists.
Yes. If there was reason to worry, if they were increasing, if they were unwell, then we would seek. I would probably have done an ultrasound, in the first instance as well.
And what would you have told the patients?
Would you have
told them about hepatitis?
Yes, but like I said, they were also very well informed, But yes, we would have discussed it, yes, the possibilities, etc.
And
I think it depends on individual circumstance, isn't it? I mean, you were asking a generalization. And patients, they're individuals at the end of the day.
Would you, but if you suspected non-A, non-B, would you give, irrespective of who the patient is, would you have given advice about not infecting others, do you think?
If the suspicion was high enough, if there was sufficient abnormality, then the answer is yes. But, one of the problems is, like we said, we think non-A, non-B. How much knowledge did we have? Otherwise, we wouldn't call them non-A, non-B until we had the hepatitis C diagnostic test. It was a grey area for everyone.
So were you cautious about passing this information on to patients during this period before hepatitis C had been described?
One thing about haemophiliacs, with most of them were intelligent. They were very nice people, very intelligent. They had come to know me and my staff very well, and we could talk, we could discuss things. There was no problem discussing anything about their tests at all, at any time. I think the danger was when you didn't discuss or you kept things away from them. Honesty paid with patients, haemophilia patients, because that was something they had to latch on. There wasn't much they could, we were their friends. They had to rely on what we said. Doctors were terribly important to them,
I'm going to move on now to knowledge of HIV. Can you recall when you first became aware of AIDS?
Like I said, we were always desperate for knowledge and information, and as soon as it must have been first case I think was in 83, wasn't it? I think by 84 we were aware. As soon as the test came, we tested people. So it must have been around 84, I think. I can't recall when the tests were. Was it 1984 it was available?
Yes, well, I'll show you some documentation in relation to that in due course. So can I ask you again, the Inquiry have sent you a number of publications that were coming out at around the time that the information about AIDS was emerging. The first one is PRSE 40523. And this is the MMWR report from July 1982. And the first paragraph there says that CDC has recently received reports of 3 cases of PCP pneumonia among patients with haemophilia A and without other underlying diseases. 2 have died, 1 remains critically ill, all 3 heterosexual males with no IV drug abuse, and all had lymphoma, etc. And then over the...
lymphopenia.
Sorry. And then over the page, page 2, under editorial note, second paragraph down, the clinical and immunologic features of these 3 patients' share are strikingly similar to those recently observed among certain individuals from the following groups: homosexual males, heterosexuals, IV drug abusers, Haitians, recently entered the United States. And then, although the cause of the severe immune dysfunction is unknown, the occurrence among the 3 haemophiliac cases suggests the possible transmission of an agent through blood products. And then the last paragraph on that page, it notes CDC has notified directors of haemophilia centres about these cases, and with the National Haemophilia Foundation has initiated collaborative surveillance. Do you remember? Would you have seen that? Is that something you would have seen at the time?
Yes, I was aware of that. Yeah.
So
I can't tell you exactly which date or when. That may have come from one of what documents I gave you. I don't know.
So it came out in July 1982. Do you think you would have seen it fairly soon after that?
I would, I might not have seen it because it's American, but I would have heard of it. I mean, that was big news, wasn't it?
Yes,
very relevant.
And you're a centre director by now.
Yes.
And having discussions with your colleagues at presumably quite high level, and that's something. So reasonably soon after this came out, you think it's likely you would have been aware of it. And then, if Henry, we can go to PRSE 402410, which is a paper from the New England Journal of Medicine from January 1983. I think you said you had a subscription to this journal. Is that right?
Yes, I had. Yes, New England Journal. Yes.
Yeah, and if we go, Henry, to the right-hand column, last paragraph, now we are becoming aware that treating haemophiliacs with factor VIII preparations may exact a high cost. Reports from the CDC include 3 haemophiliacs among cases of acquired immunodeficiency syndrome. Only recently recognised, this syndrome is associated with abnormalities of immunoregulation and a profound susceptibility to opportunistic infections. It is eventually fatal in many patients. And then over the page, please, Henry, to the, again, last paragraph on that left-hand column, the fact that haemophiliacs are at risk for AIDS is becoming clear. If the use of cryoprecipitate will minimise this risk, the current home infusion programme needs to be revised. Do you recall having discussions then with your colleagues about the recommendations in here or the suggestions in here?
I can't recall having discussions within the region. I'm not even sure whether there were communications. There must have been something. But this was at a time we were listening very carefully to UK CDO. And there were a lot of mixed messages, starting from, it doesn't apply to British products, it doesn't, that this is one-off, this is early, etc. And what were we to do about it? And it's just too early, I don't think we could have done anything really. We were waiting, again, for instruction or guidance or...
So we'll look in a moment about some of the messages that are coming from UKHCDO. I just want to take this in chronological order, if I may. Henry, can we have PARA 5013? Now, this is a document that was in your papers, and it seems to be a meeting from March the 8th, 1983, and it's not a terribly good copy, but it seems to be the Hemostats Club.
Hemostasis Club.
Hemostasis Club. What was that?
I don't know, because it says Professor Jean Lusher, that's American. So whether this was from there or whether somebody had copied, typed out information from that Hemostasis Club, I don't know. But it says Professor Jean Lusher.
Yes.
It starts very strangely. It says, or if you have missed herpes, this is all you need to know about it.
Yes. So if we turn over the page to the 3 paragraphs up, there are no reports of AIDS in the UK haemophiliacs yet. It does seem to suggest that this is a paper that was concerned anyway with the UK, albeit given by an American professor.
But I think there was Hemostasis Club in UK. So
Yes.
whether they transcribed,
Do you know?
I wasn't part of it.
You weren't part of it. Did you ever go to any of their meetings?
No.
And
I
do
think
you
this
know
was-
who was a part of it?
Well, it would be some members of the UK CDO, and I honestly couldn't tell you, but it wasn't.
So
I
this is
wasn't part
not a meeting you would have gone to.
No, or whether it was something in the southeast, around that area. I don't know.
And do you have any recollection of how this document came to be in your possession?
No, I can't recall whether, but it's been sent to me, obviously. Now, whether it was sent through the region, through Leeds, or whether it was sent from somewhere else, I have no recollection. But it's a very poor type, isn't it?
It is, and unfortunately, some of the bottom half of the second page is missing as well. And so can you help us at all with when you would have received that?
No, not really. But it's an important document, and I think it's from the UK Hemostasis Group. And I think it would have involved the directors from the southeast England,
And did you have a channel of communication with them for the exchange of information?
No, not really, no.
And we can see what's being said there, that the distribution of those with AIDS, 1% haemophiliacs, that's under distribution, and then...
I think you're on the previous page, are you?
Sorry, go first page, sorry, Henry. So under distribution, we can see haemophiliacs 1%, and then under geographical distribution, it says mortality 80% so far.
Just pausing there, that 1% is 1% of, let's just go up the page a bit, please, Henry, of the 1,250 cases.
Yes.
So that's going to be 12 cases.
Yes. And then underneath mortality, it says the Communicable Disease Centre, CDC in USA, postulates AIDS is caused by transmissible agent, probably new or variant. Mutant virus, which entered populations in 78, 79. And then it says problem accentuated by fast lane type individuals with as many as hundreds or thousands of sexual contacts, and these individuals also tend to sell or donate blood, hence the possible reason for haemophiliacs coming into the chain. And then over the page, AIDS shares some common properties with hepatitis B, i.e. long incubation period, which has been deduced from victims who have received only one blood donation contracting AIDS 12 months later. And then below immunological defects, it says it is possible that haemophiliacs have altered T4-T8 ratio and immune status from continual antigenic bombardment and therefore succumb to AIDS-type virus more easily. And then it sets out the recommendations from the US National Treatment Council. Use cryo or FF fresh frozen plasma for children under 4. Use DDAVP where possible. Don't undertake elective surgery if possible. No longer obtain concentrate donations from high-risk areas. Attempt to screen out high-risk groups, e.g. use questionnaire. Number 6, heat treat concentrate to reduce virus. 7, suggestion reduced to use porcine factor 8 only, what grotty viruses do pigs have, and then it says there are no reports of AIDS in UK haemophiliacs yet. And then there is a paragraph at the bottom of that which is cut off. There was some discussion relating to lack of cases in UK, but it was pointed something, the epidemic may yet come. And the implications of this happening are cause for great concern. So would you agree that
we've missed that? Is that on the other page?
Oh, sorry, the next page. I'm sorry, I beg your pardon. So go over to the next page. The implication of this happening are cause for great concern. So would you agree that that document contains really all of the key information about AIDS, that it's a transmissible, via a transmissible agent, blood, haemophiliacs are a particular risk for that reason, and so on, and setting out treatment recommendations. So that document provides all the key information that would be of huge significance to somebody treating people with haemophilia over this in March '83.
Absolutely, and I think all that information is American. Obviously, somebody's brought it to the hemostasis club here, I think, in the UK, and printed it very badly. And it's also the last paragraph is slightly mixed up with that's acute lymphoblastic leukemia trials. But anyway.
Can you help just on the point of whether it's American or British? Dr. Lilliman, do you know of Dr. Lilliman?
Yes, he's a pediatrician.
In England?
In England, yeah, it's British, but Lusher is American.
Yes, so it seems to be a rather mixed production.
Yes, but I think this was always important, that what information, Americans were well ahead with information, research, etc. It's how it translated to Britain. And if it was now, I presume that there are organizations in Britain that would have picked up immediately and taken action, the medicines, whatever, Here it seems that you had the information, it was how it was going to be used in Britain and who's going to be responsible for noting this information and doing something about it. And people like us were really waiting for instruction, basically, not just knowledge, but instruction. And if there was any suspicion of any of the products having this, because it says that American product, they were already thinking of litigations, they were already putting warnings on the products. But the same products were coming here and nothing was happening. And we were not independent to make decisions ourselves. We needed guidance, we needed leadership in this. Now, but that leadership could be from UK HCDO, it could have been from Medicine Agency, it could have been from all sorts of things, but I don't think we actually got. But there was a lot of this business, we're not sure what it means, British product, there's been no cases in Britain. Well, once you get cases in Britain, it's too late because the horse is bolted, and that's what's exactly the history. I think that's what happened, is we got all these cases while people were waiting for them to happen, and they did happen.
About this time, there was quite a lot of talk in the press, I think, in New Scientist and The Observer in January of 1983. Yes. So that obviously is the press, and you may read the media, I suppose, with the same eye that others do. You may think, well, do they really know what they're talking about? But it does raise questions, doesn't it?
Yes, and this is where I must say, I feel sorry, that with better guidance, with better leadership, whether it, whatever source, we were only minions in the big cogwheel, We were not even a reference center. But with better leadership from whatever source, we may have saved some cases, not all. We may have done better than we did.
Now, you said that this particular document in March of 1983 was a particularly important document to you.
Yes, but I can't recall when I received it or how I received it. But it's a very important document, and I'm sure you will be able to find out what this hemostasis club is and find the minutes,
Why do you regard it as so important, this particular document?
Because it looks like pre-publication. It looks like, you see, one of the things that there were small groups in America that produced their own newsletters. I'm trying to think of the lady that used to do it in California. She used to produce her own newsletter. And I think this information may have been from within their own discussions. But as I mentioned before, there was by the time it reached publication, there would be a delay of a year, maybe 6 months. So I suspect this was probably being discussed because there was possibility of litigations. They're already talking of somebody being sued. I think Americans are well aware of possibilities what if things went wrong therapeutically. And, unlike in Britain, I think now it's obviously different. I don't know.
Right, but thank you very much.
So having seen that New England Journal article in January 1983 that we went to earlier, would you agree that patients around about that time needed to be told that there was a real risk that blood products could transmit AIDS? Not that it was certain, but that there was a real risk that was the case.
If you did that, what were the alternatives we were going to offer them? It's like when you do a blood test, if you get an abnormal result, if you're going to do, then you should know what you're going to do about it. I think at that stage, what we were really saying to everybody and to ourselves, or convincing ourselves, let's wait for more information from people who are more learned than me, who have more at risk than me, more patients than me. Let's try and hear from the people who really matter in this country. And we were getting very mixed messages, as you know. And I think you've got all those articles and documents to say what mixed messages there were.
So there was no solution that could come from the medical world at that point, but it would have made a difference to patients, wouldn't it? Because they would have then had a choice about whether or not, for example, they wanted to continue with their treatment or what decisions they were going to make about their treatment, knowing the risk.
You see, the alternative, if we were talking to them, then they would say, well, doctor, what about NHS factor? You couldn't say that NHS factor rate from up to 5 to 10,000 donors couldn't carry a risk. You couldn't say that.
No.
If you said, okay, go to cryoprecipitate, you couldn't promise them and then tell them to use cryoprecipitate, which is really a very, very difficult thing to use, So what you'd be telling is, okay, you're going to go backwards to the treatment of the 60s and 70s. And you must, at the end of the day, factor VIII revolutionized hemophilia care. If you had seen how badly deformed, what deformities hemophiliacs had and what sort of and the lifespan was reduced down to 40 or 50 years in the 1950s. In the 80s, their lifespan was normal. So I think one has to be careful to say, no, look, we're going to turn the clock back now. Sorry, we made a mistake, or we think we're going to make a mistake. It doesn't quite work like that. What we needed was to say, right, this is a possibility. What is the government doing? What is the health services doing? What is the reference centers doing? What are the scientists doing? What are the pharmaceutical companies doing about this? And I think they were trying. I think they were trying very hard. But I think in America they were trying harder than we were trying in Britain. Although America had obviously their own problems about their donors and so on. Britain was an ideal place actually because they had good British donors, well tried out, and that maybe the BPL and NHS should have taken a lead there,
And when do you think that you did start telling your patients about the risk of AIDS?
I think when we knew the risks of AIDS, or what are the chances of risks of AIDS, you see, by the time we could test people for AIDS, they were already positive. There's quite a lot of them positive. I think in our center, probably less than other places. And I think what you got with Adrian Minford, there were 4 children, which is low, but serious. But by the time we were able to test them, quite a lot were already infected.
So do you think, and I appreciate I'm asking you to remember things a long time ago, but do you think you weren't having discussions with your patients about the risk of AIDS before the test became available, for example?
We might, I can't tell you, because they read the press. They have access to media as much as I have.
And so what patients were coming to you in clinic and asking about it, were they?
They probably would have, and I would have talked frankly about it.
Do you have any actual recollection of that?
I couldn't, because it's a whole period full of there were memories we didn't really want to bring back until this we had ourselves as directors had quite traumatic period, in the 80s. But I can't recall, honestly. I could try very hard, but we were, you see, at that time, in the 80s, there was a lot of resistance from the gay rights group that we shouldn't even be testing people. That we shouldn't be testing them, and we shouldn't be telling them we should. And in Bradford, I remember having a difficult time because, all right, you should counsel them and test them and so on. But there was this opposition that you should keep HIV out of hospitals everywhere. Sorry.
No. Don't apologise to me. But doing the timing, you think, of when you started speaking to patients about AIDS was when you knew. You said when you knew about it, when you understood that it was transmitted by blood. Is that when you think you would have told them?
I think the main time to discuss and talk about this was when the test was available, because it was very important that we shared.
So, and it was something you could do.
Yes, but there was a movement to say, don't tell them, which we totally disagreed with them. Actually, when you look at the earlier, you showed this, our comprehensive care, you'll see that we tried to have a counselor, social worker, etc. We tried to have a comprehensive, and we tried to have clinics where we could give them time to talk about it, So as soon as there was any possibility of patients having HIV, we would discuss it, Like I said, you can achieve a lot of things by being honest with patients. They're quite intelligent and they're very knowledgeable generally,
So we're going to look, I know at the time, sir, we're going to look at some of the contemporaneous documents after lunch, and it may be that will assist your memory in
yes, well, we'll take a break now until 2 o'clock. So 2 o'clock, the same rules apply. So 2 o'clock, please.